Adrenoleukodystrophy, also called ALD, Lorenzo's oil disease, and AMN. Please note the information in this presentation is up to date as of March 2020. Adrenoleukodystrophy. Adrenoleukodystrophy comes from the word adreno, meaning the adrenal glands, leuko from the word for white in Greek, and dystrophy. It is often called ALD for short, or AMN, referring to the adult form of the disease. ALD is an X-linked genetic disease. It is caused by a mutation in the ABCD1 gene, which is housed on the X chromosome. As a result of the mutation, there is a buildup of very long-chain fatty acids in the body. We believe that ALD occurs in about 1 in every 13,500 births. This makes it the most commonly inherited leukodystrophy. As we noted, ALD is passed on the X chromosome, and as such has a typical X-linked gene inheritance pattern. There is, of course, testing that can be done either prenatally or during pregnancy, and genetic counseling is strongly advised. To remind you, here is how X-linked diseases are genetically inherited for both a female affected with the disease and a male. Children are born with ALD, meaning that they have the genetic mutation. For boys, they can go on throughout their life to develop any 1, 2, or all 3 types of the disease. These different phenotypes are called adrenal insufficiency, cerebral ALD, meaning the phenotype that affects the brain, and AMN, which is the form of the disease that occurs in adulthood, affecting primarily the spinal cord and to a lesser degree the peripheral nerves. While men can have any of these symptoms or all 3 throughout their lives, women typically only present with spinal cord disease, or what is now called female ALD. We are fortunate to have newborn screening thanks in great part to the work done by Ann Moser and her late husband, Dr. Hugo Moser, along with Elisa Seeger, who has spearheaded getting testing spread throughout the country. The testing is done on a dried blood spot, and you can see the data here for how the testing is done and how many states as of this presentation are currently screening. Here is a map of all of the states that as of March 2020 are screening for ALD, along with the states that are in efforts to get screening live, along with the single pilot study which is ongoing in Massachusetts as of today. It's important to remember that although ALD is an X-linked disease, women are in fact often affected by the disease. We believe that as many as 80% of women have some symptoms of the disease, with this number going up with age. Women are extremely unlikely to present with cerebral ALD or adrenal insufficiency, but can present with symptoms in adulthood that are similar to Adrenomeyloneuropathy. These symptoms typically include bladder, bowel, and gait changes. Women have been a very largely understudied group, and so our understanding of the symptoms that impact them is changing and is really not well understood today. How do you diagnose ALD? In males, we use what's called plasma very long-chain fatty acids. This test has to be done on fasting blood. We then use genetic testing for the ABCD1 gene to find a confirmatory mutation. In females, it is not recommended to test with the very long-chain fatty acids. This is because we know that only 80% of females affected by the disease have detectable elevations in their very long-chain fatty acids. Therefore, we recommend targeted genetic testing for women. ABCD1 gene has been documented on this website. The website is run by Dr. Stefan Kemp and his group, and they keep a list of every reported mutation and whether or not the mutation has been reported as being pathogenic. It's important to remember that there is no genotype-phenotype correlation. This means that you cannot tell which of the three phenotypes a patient will have based simply on their genetic mutation. However, this website is still very helpful for showing us or giving us an idea of whether or not the mutation is truly disease-causing. Now we're going to talk about cerebral ALD. As you may know, cerebral ALD is the most severe form of ALD. It's also why it is a leukodystrophy. Cerebral ALD is most common in childhood, with 30 to 40% of boys developing cerebral ALD sometime in early childhood. The peak age, or the most common ages for this to develop, are between 4 and 9. It's important to remember that although this type of disease is most common in childhood, it can also occur in adulthood, with up to 20% of men developing the disease. Cerebral ALD is treatable when it is caught early. We treat the disease with a traditional stem cell transplant. Doctors have successfully done transplants since the early 1990s. More recently, research has been done into gene therapy, but this is not an approved treatment at this time. While treatment can work, it does take at least 6 to 12 months to halt the disease. That is why we always consider a new diagnosis to be urgent, because time is not on the side of a child or adult with cerebral ALD. We know that MRI changes can be seen in boys and men with ALD before they will have any symptoms. The time between the changes on MRI and their symptoms gives us a window with which we can treat the disease without them hopefully having any significant symptoms. To give you an idea of the natural history of untreated cerebral ALD, here is a depiction of how the MRI changes in addition to how symptoms progress. In the box, you can see that traditionally we saw initial symptoms begin with this lesion in the back of the brain. At the time a child or adult already had symptoms, the lesion already was a decent size and quickly progresses, with most children and adults being left with significant disability within 1 to 2 years' time. In fact, most children from the time of initial symptoms will lose the ability to walk and talk within 1 year. In the advent of newborn screening and additional family screening, we are now often able to detect cerebral disease when the lesion is very small, as you can see under the no symptoms category. These children have no symptoms and have a small lesion. This is why newborn screening is so important. It's also important to note that 10 to 15% of people with cerebral ALD disease have self-halting. This means that for reasons we don't understand, the disease stops progressing on its own. We believe this is most common around the onset of puberty, but honestly, we don't know because we don't really watch to see if patients will fall in this 10 to 15%. As I noted, treatment of cerebral ALD is possible and is most successful when the treatment is done early in the course. Traditionally, we have looked at survival rates, meaning did the child live? More recently, doctors and nurses, particularly out of the University of Minnesota, have looked at what symptoms children have. We know that the earlier disease is caught, the much better outcome children have, both with less fatality and with less symptoms. Results can be best obtained when a child is lucky enough to have a perfect match sibling, as this reduces the risk of graft versus host. It should also be noted that there is some evidence that the use of N-acetylcysteine during transplant may help slow the progression of disease. As a result, most centers will choose to give a dose of high-dose IV N-acetylcysteine at the time of admission, followed by a prolonged course of oral N-acetylcysteine. Trials have been conducted to see if gene therapy can also be effective in treating cerebral ALD. The first of these studies was published in 2017 and showed similar benefit to traditional stem cell transplant. This trial is published but has not been approved by the FDA, and so this is not an approved treatment at this time. Now, you've heard us mention that transplant is most effective in cerebral ALD when the disease is caught early in the course. So how do we decide what is early disease versus what is more advanced and higher risk disease? We look at two things. The first is, how does the kid look in your office? Have they had any evidence of developmental regression? Is there something they used to be able to do that they can't do anymore? Did they used to be potty trained and now all of a sudden they're having daytime accidents? To help us to qualify or quantify rather that neurologic function, we use what's called the neurologic function scale, which you can see here. The neurologic function scale gives 1 point for each symptom that can be seen commonly in advanced cerebral ALD. A score of 0 to 1 is considered early disease, and anything over 1 is considered advanced disease. We often also use neuropsychological testing. While the testing itself is likely not going to be a way that we decide if a child has advanced disease or early, it gives us a good tool to help measure their progress over time and to help us to understand if there are more subtle cognitive losses following treatment than can be seen on the neurologic function scale alone. The second thing we look at when determining early versus late disease is the MRI score. When looking at the MRI score, we use what's called the LESS score. This is a 34-point scale with 1 point being given for each region of the brain that the lesion touches. A score of under 9 or less, is considered early disease, and a score above that is considered more advanced. We also look at contrast enhancement, which we'll go over in a minute. Let's take a minute to review the MRI findings that are seen in cerebral ALD. On these images that we're looking at, healthy white matter looks like dark black on the imaging. You can see the healthy white matter up here. The lesion, on the other hand, is the white hyperintensity here and also right down here. You can see the score of 1 has a very small lesion, where the score of the 15 is larger. The LESS score gives 1 point for every region of the brain that the lesion touches. You can think of somebody having drawn a map across the brain, and if that lesion touches any part of a certain state or portion of the brain, you get 1 point for that. In addition to looking at how large a lesion is on the brain, the second thing we look at is whether or not there is contrast enhancement. This is very important in ALD because, as I noted, up to 10 to 15% of patients with cerebral ALD will have disease that stops on its own. We call this self-halting. We don't want to treat a child or adult who has self-halted disease because we don't believe they are at risk for it continuing to grow. Contrast enhancement tells us whether or not the lesion is active or if it is halted. This is because active cerebral ALD is an inflammatory disease with significant breakdown of the blood-brain barrier. You can see here 2 MRIs, both of which have positive contrast enhancement. On the one side, you can see that the lesion has been highlighted, if you will, or the entire lesion lights up with contrast enhancement. On the other image, this is the more classic, what we call garland ring of enhancement. And we think that lesions begin with that first more blushing or total Lesion is enhanced. It looks like someone's highlighted over the lesion with enhancement. And over time, that develops into this ring of contrast enhancement where the lesion's outside edges light up with enhancement. People often refer to this stage of disease as behaving like a forest fire. The destruction just is out of control and moves very quickly. I also listed here just a quick hint for all of us who are not neuroradiologists to remember that this positive contrast enhancement is really very unique to cerebral ALD. The only other leukodystrophy that we also commonly see positive contrast enhancement is Alexander's disease. Let's briefly look at the locations that the cerebral ALD lesions can occur. And I hope this will become clear why I think this is important once we talk about the next slide. So those first images that we looked at, all of the lesions occurred in the back of the brain, which is called the posterior region hugging the splenium back here. And this is where about 80% of cerebral ALD lesions occur. They can also occur in the front of the brain, in the internal capsule, or in the back of the brain in the region of the cerebellum. Look here and you'll see though that all of these lesions are occurring in the center of the brain and are quite symmetric, right? Now that we've reviewed the different locations that childhood or adult cerebral ALD can occur in the brain, let's look at terminal myelination zones. When we are born as infants, none of us have full myelination of our brain. On MRI, we cannot see full myelination until around age 2, although we believe that the brain continues to myelinate up until very early 20s, early adulthood. When that myelin is laid, sometimes we are left with what's called terminal myelination zones. Terminal myelination zones can look like little white hyperintensities, and they occur at the tips of the ventricles. So you can see it on this image here and here, but it can also occur at the back of the brain, like back here. The important thing is that it's happening at the tips of the ventricles, not in the center of the brain, like where we see cerebral ALD. The other significant difference between terminal myelination zones, which is a normal variant that can be seen on MRI, and cerebral ALD is that terminal myelination zones will not have contrast enhancement. On the other hand, cerebral ALD that is active should have contrast enhancement. This can be very confusing when an MRI is being read by an adult neuroradiologist who is not used to seeing children who can have these terminal myelination zones be quite prominent. This is one reason why it is so important that the MRIs of children with ALD are reviewed by an expert in the field to make sure that no child is sent to move forward with transplant with a normal MRI finding. Now that we've kind of covered how we determine low risk versus high risk, let's go over high risk cerebral ALD. We hope that high-risk cerebral ALD will happen less and less in the era of newborn screening, but unfortunately today we still see children and adults every year that have more high-risk cerebral ALD. High risk, again, is described as anyone who is clinically symptomatic. That means they've had a change in personality, they've lost some skills, they have some type of changes to how they're performing in day-to-day life, and on that scale the NFS is 2 or more. Independent of their NFS or of their MRI lesion size, a child or adult who has had a non-febrile seizure is also considered to be at higher risk. And then of course finally an MRI score greater than 9 is considered higher risk. For our adult patients, if they have a neurogenic bladder and are not continent of their urine, these patients are also considered a higher risk. And this is because their risk of urosepsis with the treatment of a transplant is quite high and needs to really be considered with whoever is going to be their transplant doctor. So what do you do if someone comes in and they are considered high risk? The important thing to remember is that these patients need to be counseled on the added risks of going forward with a transplant, meaning that their risk of having significant neurologic deficits at the end of treatment is quite high. If the family still decides to move forward, it is particularly important to use the N-acetylcysteine and, most importantly, to move very, very fast in getting them to transplant, as we know that time is not on our side. Recently, some centers have used seizure prophylaxis at the time of transplant. There is no data whatsoever to support this, but it's something that we do, and so this is why I mentioned it here. So in the age of newborn screening, there have been many questions regarding when to get MRIs and whether or not to give contrast. This group of professionals and patient advocates, you can see here, put together a work group who has come up with a consensus on when to screen with MRIs for children identified with ALD based on newborn screening or family screening. You can see the recommendation here. As of March 2020, this publication has been submitted but has not been published. So our recommendation is that the first MRI happen between the ages of 1 and 18 months. A second MRI should be performed around age 2 to 2.5 years old, and then beginning at age 3 until the child enters puberty or age 12, the MRI should be performed every 6 months. We have also listed general recommendations for non-ALD specialists on when to administer contrast enhancement. The reason for these recommendations are to give contrast when the risk of developing a cerebral lesion is at its greatest. There has been a lot of debate over whether or not to give contrast with every MRI. The reason for this is that there is some evidence that over time contrast can deposit in the brain. While there is no evidence as of this date that that leads to any symptoms in a child, most of us are trying to limit how much contrast we're giving children if we can. Now let's go over adrenal insufficiency. As you could guess from the name Adrenoleukodystrophy, the adrenal glands are also affected in Adrenoleukodystrophy. The adrenal glands sit on top of the kidneys and are responsible for making cortisol, along with other hormones, including sex hormones. You can see here that the brain produces ACTH, which tells the adrenal glands to make cortisol. Cortisol then signals back to the brain, okay, I have enough ACTH, you can stop making that. Cortisol is important for controlling blood pressure, glucose, and fighting off infection and controlling inflammation in the body. In adrenal insufficiency caused by adrenoleukodystrophy, the adrenal glands are damaged. As a result, they are not able to make cortisol or not able to make sufficient cortisol. The cortisol levels lower, which then results in the brain not getting the signal to stop making ACTH. As a result, the ACTH level rises. In children, or males rather, that are in childhood are diagnosed with adrenal insufficiency, we know that as many as 30% of those boys will also have ALD. There's been a lot of work to educate endocrinologists on this statistic, and we see more and more boys being diagnosed with adrenoleukodystrophy based on adrenal insufficiency every year. In fact, just last year, we were able to transplant 2 boys successfully with an early lesion after they were diagnosed first with adrenal insufficiency and subsequently diagnosed with ALD, and that's just at our center. So what do we know about adrenal insufficiency in ALD? We know that over the lifetime, men have an 80% chance of developing adrenal insufficiency. This is most commonly developed in the first decade of life, but you can see that about 28% of men develop the disease between age 10 and 40, and a very small group, only 5%, will develop adrenal insufficiency after age 40. Fortunately, This type of disease is very treatable with the use of oral medications. You can see in this picture that the child has very dark gums, which is a sign of adrenal insufficiency. Other classic symptoms are a dark tan, orangey color tan of the skin with no tan lines. You can also see hyperpigmentation sometimes of the nail beds. Clinically, children with chronic adrenal insufficiency can have low appetite. They may have trouble gaining weight. They can have salt craving, again, the dark skin, and they can get very sick easily from an infection. Unfortunately, adrenal insufficiency in and of itself can be a life-threatening condition. When the body is not able to fight off infections, they can have low blood pressure, they can become dehydrated, become very tired, and eventually can go into hypovolemic shock. This is why it's so important to catch adrenal insufficiency and treat it. In 2018, a group of endocrinologists published a guideline detailing how to screen boys with ALD for adrenal insufficiency. You can see the publication here, and I strongly recommend you look it up and read it. The recommendation tells us when to have boys tested with blood work and also goes over when to start treatment. Both start treatment with daily replacement of steroids in addition to boys who may not yet need daily replacement but do require extra steroid dosing in the setting of infection. This is just a graph of the recommendation put out in this article. So you can see that the recommendation for children under the age of 2 is to test ACTH and cortisol levels every 4 to 6 months, and then that spreads out as the child gets older. So the final type of disease that we see in adrenoleukodystrophy is something called Adrenomyloneuropathy, or AMN for short. This is the only type of ALD that we believe women can also commonly get, although there's debate as to whether or not the female version should be called Adrenomyloneuropathy or myeloneuropathy associated with adrenoleukodystrophy. For this presentation, we're going to focus on what we know about AMN in men. So we know that the vast majority of men will have some symptoms of adrenomyloneuropathy by age 60. What those symptoms look like can vary a lot, and the severity absolutely varies a lot. Usually symptoms begin in the second and third decades of life. Symptoms progress very slowly over years and even decades. Most often we see bladder and bowel function difficulties. This can be urinary urgency, urinary frequency, bowel urgency, frequency, or at times incontinence. Erectile dysfunction is one of the most common presenting symptoms, we believe. There can also be changes in gait, and this looks like a hereditary spastic paraplegia, with spasticity in the legs, tightness, loss of vibration sensation is common, difficulty with proprioception, all these more long track symptoms. Unfortunately, today we don't have any treatment specific for adrenomyloneuropathy, but there is ongoing research to try and find ways to treat this type of disease. For now, we are left to treat symptomatically. Now, you may remember that on one of the very early slides, we said that adults can also develop cerebral ALD. While it is less common than childhood for men to develop cerebral disease in adulthood, we still think that at least 20% of men can develop cerebral ALD. So how do we tell the difference between adrenomyloneuropathy, or AMN, and adult cerebral ALD? So as I just stated, AMN is a gradual change, so it happens over many years. Now, it should be noted that some men will reach a tipping point, so maybe their gait has been a little different for a long time, but it didn't impact how they were able to get around. When they first start having to use a cane, that can feel like a rapid, sudden change, but your history should be able to help guide you that it's actually been building for a while. In AMN, the symptoms usually start in the legs and slowly progress up. The arms are much less commonly affected. Bowel and bladder symptoms are common, but there should not be any cognitive changes. And, of course, the MRI should not show any cerebral disease. Most specifically, you should not see any lesions in the brain that have positive contrast enhancement. Adult cerebral ALD, on the other hand, usually is described as a more rapid change. These men also have changes in personality. They may have trouble staying on top of their bills, have had a change in work performance, have lost a job. Family members may say that they become angry all of a sudden more frequently. They can also, of course, have more central findings, including changes in their speech, inappropriate joking. They can have upper body findings more so than lower body. You can see this sometimes on finger-nose finger testing. And of course, their MRI will have a lesion. To help make sure that we can tell the difference, it is recommended that even adults with ALD have an MRI performed every year. So what are active trials? Now, depending on when you're listening to this talk, the active clinical trials may change, and we would recommend that you look at clinicaltrials.gov to look at what trials are actively enrolling as of today. In March 2020, there is currently still a pilot vitamin D study being performed out of Stanford, California. For cerebral ALD, there is an active gene therapy trial out of multiple sites, and in Europe only, there is a Minirex trial that is being used in early cerebral lesions. There are several trials looking at ways to improve transplant, how to improve how many cells the child receives, and other ways to improve this procedure that you can see here. There are multiple registries that are looking at the natural history of disease, and more are scheduled to open this summer. And for AMN, there is one trial, which is a Minirex trial, which is scheduled to be wrapping up the first leg of the trial this summer, the summer of 2020. And our hope is that we will have some data from that by late 2020 or early 2021, but no data is available today. So what centers are ALD centers? Well, the truth is that in the age of newborn screening, there are going to be more children and adults diagnosed with ALD every year. Our hope is that every LCN will be a center that knows ALD well and can be considered an expert. Now, to help with some of the most common questions that we hear in clinic every day, let's go over the most common questions that asymptomatic ALD families ask. So one question is, can we just do the transplant now? Well, the answer is no. So the number one reason that we don't do a transplant just at the first sign of ALD, meaning your baby has had a newborn screening positive, is that a transplant is a high-risk procedure. There's chemotherapy involved, and even with medical advances, children can still die from a transplant. On the other hand, we know that only about 30 to 40% of boys with Adrenoleukodystrophy will develop cerebral ALD. Therefore, the risk of doing a transplant without evidence of childhood cerebral ALD or adult cerebral ALD is just not a risk that is worth taking. The second thing that gets talked about less is that we don't know that a transplant can prevent cerebral ALD from developing. While there's lots of evidence that transplant can halt the progression of cerebral ALD, there is not evidence that it can in fact prevent the development of cerebral disease. And it's possible that the active inflammation that occurs during active cerebral ALD may actually signal the cells and tell them to go to that area of the brain, and that's how they are getting to the right location. The next question that often comes up is, well, then should we at least look for an HLA match or a donor to do a transplant? Again, the answer is no. If you have multiple children, or if the patient has full siblings, meaning the same mother and biological father, some families will choose to test to see if the siblings are a perfect match. This is not medically necessary, but it is not a contraindication, and you certainly can do it if the family wants. We don't recommend that you begin to look at the donor pool. And the reason for that is that the donor pool for bone marrow transplants or hematopoietic stem cell transplants is always changing. And so who is an available donor today in March 2020 may not be a donor when you need a donor. The message we always like to give families is that we should have time. So as long as we stay on top of the MRI schedule and don't miss any MRIs, we have time to find a donor. And so the most important thing is to follow the MRI recommendation. And then, of course, there's the question of Lorenzo's oil. For those of you who don't know, Lorenzo's oil, which was made into a movie, but Lorenzo's oil was developed to help lower very long-chain fatty acids. Unfortunately, Lorenzo's oil is not available in the United States. Research was not able to prove the benefit, which is why it is not available now, although many people anecdotally really believe in it. Our current recommendation is to follow a normal, healthy diet. We always try to remember families that fat is actually quite important for young children. In the first 2 years of life, you have to lay down myelin, and myelin is made of fat. And so it's recommended to follow the normal guidelines of whole milk for the first 2 years of life. Here are a few things to remember, because it can be disconcerting to just tell a family, well, it's not available, so you can't do it. Of course, we want to reassure them that there are reasons that Lorenzo's oil is not available right now. So there's no evidence that the higher your very long-chain fatty acids are, the more likely you are to develop cerebral ALD. In fact, when very long-chain fatty acids were lowered with Lorenzo's oil, we still had boys that developed cerebral ALD and still required transplant. The most important message we can send is that as long as we stay on top of screening, completing the MRIs of the brain on the regular schedule, we will catch cerebral ALD and we will be able to treat it. So what happens if he falls and hits his head? Well, so there's some evidence that a severe head trauma can increase the risk of cerebral ALD. By severe head trauma, we mean trauma that actually breaks the blood-brain barrier. So there have been cases where patients have required brain surgery, for example, having a shunt placed, and then developed cerebral ALD along the incision of where that surgery was performed. Or patients have been in a major car accident and had a brain injury and then developed cerebral ALD along those areas. There's no evidence that small head trauma, like falling and hitting your head, can cause cerebral ALD. We do recommend that patients avoid direct head contact sports such as football and ice hockey. And the reason for this is that with growing evidence that perhaps repeat concussions can also cause brain damage, we prefer that our boys not take that added risk. So it's fine for boys to play. All children fall, all children bump their heads. That's part of development. The recommendation is simply not to go into high-risk situations where there is intentional trauma to the head. So where can you learn more? Elisa Seeger and the Aidan Jack Seeger Foundation have put together a beautiful webpage and handout. We've listed the information here. This is a tremendous resource for families, particularly those diagnosed based on newborn screening, that goes over all the information on ALD, the different phenotypes of the disease, treatments available, and what families need to do today. There are also many organizations with information that we've listed for you here. These can be great resources for families and for professionals. And finally, there's resources for you as a medical provider that we've shared, including the Adrenoleukodystrophy.info website, which is the website that is led by Dr. Stefan Kemp and lists every mutation that has been reported in the ABCD1 gene that has been reported as causing disease or adrenoleukodystrophy. Here's some information you can find in the shared files for Leukodystrophy Care Network care coordinators. Thank you. We hope that this helped provide you with some information on adrenoleukodystrophy. Any of the presenters are happy to answer further questions if you should have some.